Bismillahirrahmanirrahim. Today I will explain about obstructive shock. Etiologies for obstructive shock are tension pneumothorax or pneumothorax, pericardial effusion that will lead to cardiac tamponade, pulmonary thromboembolism, and gastrodilation volvulus in dogs. In tension pneumothorax, there will be positive air pressure within the lungs. That is due to the chest cavity rupture or trauma or pleural rupture. This will create positive pressure and cranial shifting of medial sternum. These both will put pressure on a heart and will stop its filling. So the heart function will be compromised. That will be equal to shock. On auscultation, there will be no ventral lung sound, and on X-ray, there will be shifting of medial sternum. The cat comes with respiratory distress, open mouth breathing, and there are no ventral lung sound, and the treatment is thoracocentesis. The other is gastric dilation volvulus. Now the stomach in a large chest dog will rotate and will put pressure on a vena cava and stop the backward flow of blood to the heart. And again, it's an obstruction, and it's a category of obstructive shock. The heart will not be able to fill because the heart contraction is principally dependent upon its filling. If it will not fill, it will not contract as well. On an X-ray for NAVLE, remember lateral radiograph with a double bubble. So the fluids along with gastric decompression and then surgery to derotate the stomach. The other is the pericardial effusion. One of the reason is the hemangiosarcoma. This will cause the fluid within the pericardium that will compress the heart. The heart will not be able to fill completely or go into diastole. Again, there will be a obstruction and jugular distension. On an X-ray, there will be a circular heart because of the presence of fluid within the pericardium. On ECG, there will be electrical ultrons, means QRS, one QRS of good height and other is of short height. And on auscultation, there will be muffled heart sound. So again, pericardiocentesis is a treatment of choice for this category of shock. The other is the PTE, which is pulmonary thromboembolism. As I explained yesterday, anything like DIC or endothrombin 3 loss or PL, and that could lead to pulmonary thromboembolism. It will stop the blood to move, to go forward or backward. This will again create shock. In order to diagnose that, the gold standard diagnosis is the CT angiography, and drugs like heparin IV is given to break that clot. Jugular distension with shock like ascites, jugular distension, muffled heart sounds, or ventrally the sound of the lungs is absent. That is equal to obstructive shock, and each is treated according to the situation. If it is tension pneumothorax, then the chest thoracocentesis is performed and the chest tube is placed. If it is due to pericardial effusion that leads to cardiac tamponade, then there will be a pericardiocentesis. If it is GDV, first the gastric decompression with IV fluids and later surgery. And for PTE, which is pulmonary thromboembolism, anticoagulant is given.